Dear friends, welcome in this live interactive teleconference of the PGDCC program. Today we are going to discuss about the atherosclerosis. This is the one of the important topic related to the mainly coronary artery disease. But before going to the topic, there are a few important announcements I would like to make. That is, first of all, I would like to welcome all the new candidates wherever they have joined and they are join in this program. So welcome you all. And for the senior batch student, especially that is for the 2006 batch who are going to appear the tournament examination in the month of December 2008. The special announcement for them is they have to submit the application examination form, especially theory tournament examination form, to the registrar SRN-ED with 50 rupees per course exam fee. They are going to appear 3 courses, so they have to submit 50 rupees. They can also submit the form online, and they should retain the control number so that later on they can recover these things. The practical examination form student need to fill up and submit to program in charge. So program in charge means the person who is coordinating from your program, and there is no exam fee for the practical examination, but the examination will be held only after 24 months of training. So many students, they have joined in the month of January or like first week of February. So in this case, the examination date are normally decided by the program in charge, and practical examination will be definitely done after 24 months of training. But definitely the tournament theory examination will be done in the first 15 days, within first 15 days of the December 2008. The examination date you can avail it from the IGNOU website. And if you want to know the specific exam date, we can definitely inform. This time examination pattern will be little bit different, because earlier we used to have multiple choice having true and false type of answers, but this time we are planning for typical like ideal multiple type of questions, one question having 4 options and only one of them will be correct. So this is just for your information. Later on also we will communicate you through letter, but this is just to get you mentally preparation, and the number of the questions and the study examination hours will be informed to you accordingly. I know that in many centers students have not received the study material, especially the new student who has been joined. So for this purpose, I would like to request to all the new students to contact to regional director office, because this time onward regional center is going to provide you this study material, and regional center you are requested to contact with regional director for your study material. If any student have not availed the things, you can avail all this study material into from our IGNOU website also. Not only study material, but also the video program made by IGNOU for this program are also available, these things. So I would like to request Dr. Lahiri. Sorry, I introduced to I forgot to introduce my expert. He is Dr. Lahiri. He is from Delhi Lung and Heart Institute. Today he will discuss this atherosclerosis topic. So I would like to request Dr. Lahiri kindly show this IGNOU website. May I have a request to show the IGNOU website please on the screen? IGNOU website, yeah, this is our IGNOU website. So on the mainly 3rd or 4th column from our top to bottom, you can find the e-Gyan course. Just click on e-Gyan course and you will find this page. Within this page, India is the one where we are having the course material. You just click on India, and this page will open. You can just go back and click it. Just yeah, India plus के ऊपर click करिए sir. Yeah, you just click on plus. Like Indira Gandhi, you click on plus. So there will schools of health sciences coming. You click on School of Health Sciences, and there are the list of the program. And just scroll down. There you will find PGDCC program, and just click on plus. And within that, you will find the PGDCC program. Like PGDCC program, once you click there, you will find the video programs. All the study material are course wise. You can click and download. You just need to register yourself, and you just click on video programs. There are total 8 programs. Yeah, There are total 8 programs till today we are having. So anytime you can avail it, and you can simultaneously download it on your computer online, and you can see it on n numbers of time. These videos are mainly related to the like your ECG, echo, and history taken and physical examination. So I would like to request all of you kindly go through it and give us proper feedback. And beside this also, you can also avail this teleconference facility on online also. For that, I would like to request Dr. Lahiri to go through the main page again. I think it will not come.
You can go to Google.
Yeah, please go through Google. You just type on Google on that screen. So basically, this teleconference facility, IGNOU website is providing online also. So you just type IGNOU. So once you open the IGNOU website, there is a IGNOU online. So once you go to IGNOU online, just click, sir. IGNOU online, there is education broadcasting. Once you click the education broadcasting, there are education channel, the topmost corner. Yeah, there is Gyandarshan 1 channel and Gyandarshan 2 channel. Gyandarshan 1 is always available, but there are some problem maybe they are related to the Gyandarshan 2. So I would like to request all of you, you may kindly contact to your people, and you also can try these sessions and give us the feedback whether these are the available or not. Otherwise, if it is not available, we can definitely inform to the concerned department to take a corrective measures regarding this. This is the some kind of information to all of you, so that you can avail all this facility, because there are many centers where receiving terminal and is not available. So this is what about the website. And I also want to request to all of you, not only the older student but new batch student also, please read the program guide carefully, because sometimes I get very much disappointed. There are many things which is simply written on the program guide, but people used to call me every time for the simple reason. These are some unfortunate things. This year we have revised our program guide, and all of you are requested to read program guide carefully. And you can write email like pgdcc@ignou.ac.in. That is the PGDCC related email. And you can also call me anytime, especially for the new student. My mobile number is 9810201401. You can also send SMS through this during these sessions also, because within these sessions I definitely cannot talk to you. But here coming to the main topic, that is atherosclerosis. So regarding atherosclerosis, this is a process that all of you know, by which some kind of depositions occur in the lumen of the artery, and there are some specific type of artery where this depositions is more. If it is more only more on like coronary artery, then it results to coronary artery like myocardial infarction disease. If it is on the cerebral artery, then it results to stroke or some kind of cerebral ischemia. If it is on the renal artery, so it is across the body all over, but there are some special organ related artery where it involves more. So definitely myocardial infarction is one of the challenging in cardiology unit, and atherosclerosis is the major cause of it, one of the major cause of it. So to discuss all these things, we are having Dr. Lahiri, and all of you are requested to contact, interact in this session, so that we can know at least where are the students are sitting. Although you may not have any questions in your mind, but you can just send SMS also in my mobile number, and you can inform where you are and how much you have been benefited and what kind of program you are really looking for. I am repeating my number again, and my number is 9810201401. I am also requesting our studio to display our studio number, because this is the first time our students are there, so they should avail the fax number as well as the telephone number. Our studio telephone number is 01129532845, and second number is 01129532844. The toll-free number is also there, that is 1800112345. Fax number you can write 01129536134. So all of you are requested to interact so that we can understand that you are really benefited by this program. Not wasting too much time, I would like to request Dr. Lahiri to start with this topic. Dr. Lahiri,
Thank
please.
you very much, Dr. Biplav. I welcome you all here. And this is a very interesting topic, and it basically involves all the organs, this disease, and I shall discuss in details initially the anatomy, then we'll discuss the pathology, and as we go into our discussion, we'll talk about the clinical aspects, and we'll touch down on a little bit on the treatment aspects. So atherosclerosis, this is basically a pathological specimen. You can see here in this is a cross section of the vessel. This is probably a vasculature, maybe from the coronary artery, and you can see it is the whole atherosclerosis pathology. Here it is occluding the lumen, and you can see that this is the lumen of the vessel. So this is an extensive process of deposition of fibrofatty plaque out here, and which can give rise to several complications. Now atherosclerosis in Greek terminology means ather means gruel, and sclerosis means hardening. So there is basically hardening of the vessels from a gruel-like cheesy fatty material which causes this pathology. Now you can see here more than 80% of the cardiovascular death and disability is due to atherosclerosis. Here in this pie chart you can see the atherosclerotic cardiovascular disease, which is responsible for the major causes of disability and cardiovascular death, out of which 54% are because of a coronary heart disease, 18% is because of stroke, and because of atherosclerotic cardiovascular disease, patient can have congestive heart failure, high blood pressure, and also some other diseases of the peripheral vessels like the femoral arteries or the carotid arteries, which can be responsible for stroke and other miscellaneous clinical scenarios. Now this is a very good slide which shows the projection of the cardiovascular disease related deaths worldwide, and you can see here the projected figures for the 2020 is 19 million for the non-Western countries. If you compare the two charts, you can see the bar diagrams, and if you compare them, you'll find that in 1990 there were 5 million deaths from cardiovascular disease in the Western countries, and the projected figure is there's no much difference. So they have been able to control in the Western world, but look at the scenario here in the non-Western countries, like the developing countries like ours, which is projected to be a 19 million, which is a vast majority of the patients, and it is into a malignant proportions that the disease burden is in the community. So here is basically the problem, and it is in the mass population. Earlier we used to think that this is basically a disease of the affluent class, but it is not so, and in the developing world it is developing in the form of an epidemic. So the atherosclerosis is the leading cause of death and disability, as I have told, and myocardial infarction and strokes remain major heart problems despite increasing understanding of the underlying disease. Atherogenesis occurs over many years, usually many decades, and growth of plaques probably does not occur in a linear fashion, but discontinuously, with periods of quiescence punctuated by periods of rapid evolution. So there are periods you will have waxing and waning of the disease. You will have presentations where the patient will continue to remain in a stable state for quite some time, and then suddenly again will rapidly progress. And going back to the history, if you talk about the genesis of atherosclerosis, there were initial two theories, and the theories were given by the first in 1851 by Rokitansky, who said that basically it developed from a thrombogenic material. So his theory was basically a thrombogenic theory, which he stated that atherosclerosis begins in the intima and with the deposition of thrombus. So he said that there is a thrombosis in the blood vessel, and which causes this thrombus gets deposited in the intima of the vessel, and where there is an organization of this thrombus, followed by there is infiltration of the cells like fibroblasts, and there is secondary lipid deposition, which was basically challenged by Rudolf Virchow Virchow was a pioneer in establishing theories, as we all know, Virchow's triad. So he said that basically it is an inflammatory theory which suggests that atherosclerosis starts with lipid transduction in the arterial wall with lateral interaction. So Virchow was the person who challenged this theory that was given by Rokitansky, and he said that it's all because of an inflammation, and there is lateral transduction of the artery in the artery of lipids with interaction with the cellular elements, leading on to intimal proliferation. The researches were carried on, and in the 20th century, in 1940, Goffman led to the description of an atherogenic low-density lipoproteins. And it was finally Ross who proposed that. It was a unifying theory which he gave in 1976, stating that atherosclerosis results from an endothelial injury causing the endothelium to become more susceptible to lipid accumulation and thrombus deposition. Now, going back to the anatomy, if you look at the arterial wall, this is very important. We have to know the structure of the arterial wall. You can see here, this is the endothelium, which is initially it was thought like a sleeping kind of a barrier, but it is not so. It is a highly active endocrine organ and also paracrine with a paracrine and autocrine function. So it's probably the most active organ, which is always there is some molecular level, some changes are going on. Endothelium is inside the endothelium. If you go deeper into the wall, you will find the tunica media, and there is a tunica adventitia. In between the layers, there are membranes, two membranes, internal elastic lamina and external elastic lamina. And you can see here the red marks. Basically, the adventitia, these are vasa vasorum. These are vasa vasorum. They are the blood supply to the arteries itself. The major arteries will have the blood supply, very small vessels. Basically, they are invading the outer layer of the your vessel, the adventitia, and which is very important in atherosclerosis, because this blood supply, these vessels carry several cellular elements. They cause neovascularization of the plaque. So these vasa vasorum are extensive, important in the atherosclerosis. Now here you can see here that the endothelium is basically, there is always a constant balance going on in between a hemostasis, which is, versus thrombosis. So there is a procoagulant activity going on and also an anticoagulant. So the balance, if the balance in between the procoagulant and the anticoagulant activity is disturbed, will result in thrombosis, which result in vascular cascades of thrombosis and acute coronary syndromes or acute stroke, whatever may be in the organs that they involve. So the procoagulant factors are basically the endothelin-1, which is the potent vasoconstrictor, and the main function which preserves the endothelial function is governed by the nitric oxide. If you know the molecular level, nitric oxide basically is a vasodilator. So nitric oxide synthase activity is very important, which promotes normal endothelial function. And any atherosclerosis will begin with disturbance of the endothelial function. So the endothelium has got a vascular tone regulation, which is by the several vasoconstrictor and vasodilators I have told, like your endothelin-1 and the nitric oxide. There is a prostacyclin I. Prostacyclin I2 is basically a vasodilator. So that is the balance in between this nitric oxide, prostacyclin, endothelin-1, which is responsible for the final vasodilatation or vasoconstriction that occurs initially in the endothelium, which is basically the first manifestation of any vascular disease. Now, if you look at the anatomy of an atherosclerotic plaque, you'll find that if this is a cross section of the vessel, you can see here is the lumen, and this is the intima. Here is the lipid core, and you can see here the the cellular elements. So basically, you have the cellular elements. There is a lipid collection, and which is covered by a intima, which the thickness of it depends on the place where it is and also on the stage in which the plaque is. So you can see here the cellular elements. They are T lymphocytes. This is very important. Macrophages, which are the most important cell, which destines a plaque whether it will become vulnerable for rupture. And you can see the activated smooth muscle cells. These are activated smooth muscle cells. And you can see here the normal medial cells. So the smooth muscle cell originate from the media. Initially they are basically in the smooth muscles in the media, they are not in the synthetic state, they are in the contractile phase. So once they invade it, they start synthesis of various extracellular materials which increases the bulk of the plaque. So the current atherosclerosis is basically that there are stages where it starts with 3 stages mainly. The first stage is the stage of endothelial dysfunction. Now any factor, any risk factor for that matter, if it causes a disturbance of the endothelial homeostasis, it will cause basically endothelial dysfunction. Now it can be because of a LDL cholesterol which gets oxidized, which can cause an initiation of the basic endothelial dysfunction. And finally, when the endothelial dysfunction occurs, there are changes that I'll tell you. There are some chemoattractant factors which brings in the cellular elements, causes adhesion of the cells onto the intima, and finally some monocytes, they will migrate inside, they form macrophages, engulf lipids, form foam cells, and result in smooth muscle cell proliferation. So here it starts beginning from the endothelial cells. As I told you, the smooth muscle cells, which initially they are in the media and they accumulate in the intima, they change from the contractile pattern as they were in the media, and in the intima they go into a subintimal realm, they go into the synthetic phase. And there is a deposition and proliferation of extracellular matrix which forms the bulk of an advanced atherosclerotic plaque. And it is not that the persons will come with, they will be harboring atherosclerotic plaque for a long time, but suddenly there will be some disruption of the plaques, and this disruption of the plaques, while it occurs, that can occur because of some triggering factors which will result in plaque fissuring or intramural hemorrhage. As I told you, the vasa vasorum, which will cause angiogenesis inside the plaque, will cause hemorrhage in the plaque and cause a luminal occlusion. For the last 5-6 years, there have been a lot of work on the infection etiology of atherosclerosis, like chlamydia and mycoplasma. They have been thought that there is some element of infection which liberates some protein which disturbs the endothelial milieu and causes a rupture of a plaque. So you see here the gradation of the stage of atherosclerosis. This foam cells, you'll find this is particularly a microscopic feature. You'll find that there is a cellular element, the macrophages going in, penetrates the intima, and there is collection of lipid droplets inside, and when they form the foam cells. As it grows, there is further coalescence of these macrophages together, and there is heaping of lipid material which give rise to fatty streak, and this is that stage where it is discernible, and fatty streaks can occur as early as 3 years, and it can be seen in the intimal stage in many young autopsy vasculature, but you will find that not majority of them will progress to a full-fledged atherosclerosis, and as the disease grows, you will find there is collection of an extracellular material, proteoglycan, and which will give rise to increase in the plaque bulk. And here you can see here that it goes up, and you will find the lipid core deposition will further increase in the plaque, and in this phase, at one particular time, there will be rupture. So the disease, why the disease is so dangerous, in the sense that as long as the plaque grows, it will not cause any symptom unless the luminal compromise occurs, which probably will be after some 70% of the diameter stenosis of the vessel, be it in the carotid, or say 70%, where there will be some kind of a element. But now the theories are changing. You'll say that even a 50% can have a rupture, and which will cause basically a thrombosis. So there will be thrombosis cascade which will cause a total occlusion. That is the reason we see in these days you go for angiography and you find that patient has come with a myocardial infarction, but we do the angiogram, you'll find that the plaque is just 50%. That means that the plaque was 50%, but there was a crack in the plaque which had given a thrombosis. And after thrombosis, when you give antiplatelet, anticoagulants, thrombolytic agents, the thrombus dissolves and the plaque is left, which is just a 50% plaque. So basically thrombosis can occur at any stage, even a 25-30% intermediate lesion can rupture and give rise to a thrombosis cascade. Now this is the fatty streak. As I have enlarged, you can see the monocytes going inside in between the there is an endothelial denudation, endothelial breakdown, and through the in between the cells it penetrates and enters the subintimal layer, where there is oxidized LDL, and oxidized LDL are basically engulfed by this macrophages, basically, which is the monocyte which converts to macrophages subintimally and form the foam cells. So atherosclerosis is highly complex disease, often affecting multiple arteries in any individual, and risk factors have been identified, and you can see here the fatty streak, how it looks like. It's very early atherosclerotic plaque. Now once the macrophages are inside, it will liberate several cytokines. It will liberate tissue factor, and this tissue factor is very important in thrombosis. It is the beginning of the coagulation cascade, which is liberation of the tissue factor, and which will basically once the tissue factor is liberated, there will be initiation of the coagulation cascade, which will form a thrombosis inside the lumen. So you can see a lot of things are going on out here. You can see the inflammation, and there is recruitment of cells which are from the cytokines. There is formation of tissue factor, and these are oxidized LDL that is moving on inside the blood, and which will be basically taken up by the macrophages. Here you can see here that this is another slide which is showing the fibrous cap, which is because of the smooth muscle cell in the subintimal layer. The fibrous cap is forming, and depending on the vulnerability of the plaque, the fibrous cap will be thin or thick. You know, in old age, you will find patients come with angina. Majority of the time, they will have a fibrofatty plaque, which is fibrous element will be very high. And in younger generation, particularly, you will patients with comes with a 30 years old gentleman who comes with an acute myocardial infarction. You will find that they are basically having vulnerable plaque. They will have a thin plaque. And here you can see the lymphocytes, the macrophages, all the cellular element. So what exactly happens here is that the cellular element, as the plaque grows, they will have a cell death. Now we have cell death in two forms. It can be because of an inflammation, necrosis, and it can be a programmed cell death. The programmed cell death is known as apoptosis. So apoptosis occurs in lot many of atherosclerotic plaques, which will produce a non-inflammatory cell death. Apoptosis means it's basically a programmed cell death, which is non-inflammatory in nature, and you can have a cell death with inflammation and necrosis. So both of these activities are going on out here, which will increase the plaque bulk. Now here I have this is basically the vasculature. There's the I'm showing the plasma membrane, and this is how the oxidized LDL from the blood, basically they are engulfed inside the plaque. The oxidation of the lipid peroxidation is very important, in which all the risk factors, be it diabetes, hypertension, dyslipidemia, they cause an LDL oxidation, and once there is oxidation, these oxidized LDL are readily taken up by the receptors and cause endocytosis inside the vessel, and they are further engulfed by the macrophages. So this can be a receptor mediated, and this can also be, that I have not shown in the slide, the scavenger receptors. Now the scavenger receptors are there, which will only initiate only when there is a oxidized LDL. They are not meant for LDL which is not oxidized. So that is, here comes the importance of risk factors. So there has to be a free radical injury, and free radical injury will cause, say, a repeat peroxidation, and then finally they will be taken inside the cells. So you can see here the macrophages. Now when there is an endothelial injury or endothelial disruption, there will be attachment of the macrophages, and this attachment is not that they just go attached, because there is some factor that is stimulated. There are several factors, I will tell you the factors which are stimulated, which will cause the adhesion of the macrophages onto the endothelium, and then there is a penetration. So these are all governed by molecular phases. This is not that they just go in, they are by a molecular chemotactic factors, say chemokines or lymphokines, or any factor that will lead to that. I'll go into the details of that. So you can see one such factor is the VCAM1, is a vascular cell adhesion molecule. Once the monocytes get attached, they are taken inside the plaque by these adhesion molecules, and then once inside also by macrophage chemoattractant factor 1. And once there is a macrophage chemoattractant factor, after the foam cells are formed, there will be coalescence of the macrophages, and which is also done by the colony stimulating factors, macrophage colony stimulating factors. So these lymphokines are important for your purpose. At least you should try to name them. You should know that how the molecular process is a very active dynamic process going on. So you should know how it goes inside. Now we have seen that as the percentage of plaque that is occupied by macrophages, the macrophage number as it goes up, you can see here in stable angina the macrophages, the percentage of plaque occupied by macrophages are not much, whereas in unstable angina and non-ST elevated MI, these are basically the unstable phases of any coronary artery disease. So as the instability increases, the macrophages percentage will increase. That means the plaque is getting vulnerable for rupture. Okay, so you are basically in stable angina patients 70 years, they will continue with angina for quite some time, 5 years, 6 years, but they will not have a acute coronary insufficiency. Why? Majority of the time they are carrying a plaque with heavy fibrous deposition. So they will cause a luminal obstruction, they will continue for angina together, but they will not give rise to acute coronary syndrome as you see in unstable angina. Sometimes you wonder why young people come to your casualties with unstable angina, non-QMI and ST elevated MI, because they are basically the vulnerable plaques with very thin fibrous tissue, more of a lipid burden, which readily ruptures, give rise to acute thrombosis. So here the macrophage monocyte chemoattractant factor 1 is a potent mononuclear cell chemoattractant produced by endothelial cells and smooth muscle cells. It is localized in human and experimental atheroma. So this is, you should know a bit of this. I am not telling you just mug it up, but just remember that there is some kind of a chemokines that are going on, chemokines which will attract the monocytes into the plaque. Again, this vascular cell adhesion molecule 1, it also binds monocyte and lymphocytes, is found in cells in atheroma, expressed by endothelium over nascent fatty streaks. So if there are fatty streak formation, these in the fatty streaks, these are synthesized, and from there they can cause, and now these are also expressed by the microvessels of the mature atheroma. I told you microvessels, how they can grow inside the atheroma, from the vasa vasorum. Vasa vasorum are the blood vessels which are supplying the large vessels. So they are basically growth of the vessel which can cause an intra-plaque hemorrhage. So there is rupture of these microvessels inside the mature atheroma. So it has been found that an atherogenic diet rapidly induces a VCAM1, a cytokine regulatable molecule. So if your lipid diet increases, fatty diet increases, there is induction of this VCAM molecule which can cause a rapid progression of plaque. This has been seen in the rabbit aortic endothelium. And here the various cellular cells, you can see the monocytes, T lymphocytes, B lymphocytes. Polymorphonuclear cells, in fact, they are not a very common cellular finding in early stages of atherosclerosis. They are seen only in later stages where there is a plaque rupture, or there is the more the plaque become vulnerable, more the chances of getting a rupture. So polymorphonuclear cells are a late finding, particularly when the plaque ruptures or in a very late stage. You can, I was just telling about the VCAM expression in rabbit. You can see here there is an expression. This is the endothelium, and this rabbit was fed for 3 weeks, and there is expression of the molecule, and this causes increase in the plaques. Now, why does the rupture occurs of a plaque? That means if there is a fibrous tissue on the top of the heap material of atherosclerotic plaque, you should also have some rupture. The rupture can be because of various triggers, and you know what, this collagen, which is most important tissue inside the fibrous tissue, they need to be broken down before there is a rupture. So the cap ruptures, the fibrous cap ruptures because of certain proteinaceous activities, and these are known as matrix metalloproteinases, MMP. This is very important. So it's basically there inside the plaque there is some kind of a collagen degrading proteinases that are liberated from the macrophages, and as the plaque becomes vulnerable, there is more chance of this getting ruptured. So matrix metalloproteinases are several proteinases like stromalysins, you will have collagenases. Basically they will cause a breakdown of the plaque. So at your level you must know that these are the factors, and matrix metalloproteinases, the activity of increases as the plaque gets prone to rupture. And you can see here is the inside the plaque there is a lot of inflammation going on, which probably will lead on to several markers elevation in an acute coronary insufficiency. So here in the lipid core you can see that this CD40L, this is a lymphocyte. Basically with this, let's say lymphocytes, they are having a lot of markers. How can you identify? So they have got receptors, and this CD40 basically it's there is a lot of elevation of this marker, and this can be picked up in the blood. You can know that whether the person is having any vulnerable plaque inside. So the latest theories say that latest investigation, they are picking this up and they are saying that the person is vulnerable for a rupture and he can get an acute coronary insufficiency. So this is important at your level. You should know this. A lot of work is going on. CD40L. Okay, so this marker is elevated. This is a soluble form that is released from the plaque, and it is seen in the blood and it can be picked up. These are all the other things. You can see here interleukin-1. You all know that inflammation, interleukin-1 can give rise to fever and all. And as the infection theory today, inflammation theory is very important theory which says that any acute coronary insufficiency is basically a result of a systemic inflammation. So not only the local vessel is involved, and we have seen in angiograms that we perform that many a time in acute coronary insufficiency in multiple blood vessels, multiple coronary arteries are involved, multiple coronary artery related. So it's not that a single area of endothelium in the coronary artery is involved. You can have multiple number of sites which are basically hot sites, or you can say that there is inflammation that is going on. So there is coming back to this point, we will say that collagen degrading proteinases, they cause breakdown of this collagen, and that result in a rupture of that area and causes increase in the tissue factor progranulin activity, causes a thrombosis cascade. Now, as I was telling, is the interplay in between several inflammatory markers that nowadays we are picking up in patients with acute coronary syndrome, and you can see how they. So if you have got basically a stable plaque, it will not give rise to any inflammation. So this is the endothelium. You can see here the adventitia that has been depicted here, and the smooth muscles. So healthy vessel, there is an early lesion, and from an early lesion, you may progress to a vulnerable plaque, or you may progress to a stable plaque. If you have got a stable plaque, you will have more fibrous deposition, you will have a small amount of cellular element and not much inflammation. So they are called as cold plaques, where you will have in a vulnerable plaque, you will have a thin fibrous cap, and this fibrous cap will rupture. Inside the plaque, you will have a lot of inflammation, and as I told you, this is a systemic inflammation. You will find young people comes with a viral prodrome, and then they will have an acute coronary insufficiency. Many a time we will have a clinical scenario like that. And I have told you about the adhesion molecules out here in intracellular adhesion molecule, VCAM1, vascular cell E-selectin. This is secreted from the endothelium, P-selectin, platelet selectin. Means these are all the chemokines which will cause initial adhesion inside the blood vessel. And the inflammatory cytokines like interleukin-6 and tumor necrosis factor alpha. These are very important. These are inflammatory markers that are secreted from the liver. This also, so you can see that the process is taking place in the endothelium vasculature, but the liver is getting activated and produces. So it is basically a systemic process. That's the current theory is all about. So when there is an injury, here this soluble CD40, as I have told you, this can get elevated in the basically causes a vulnerable plaque, and a lot of work is being going on this. Another is phospholipase A2. That I have not, lipoprotein phospholipase A2, that is also a very important marker. That is a biomarker which is elevated in vulnerable plaque. And once there is an injury, you can, such a C-reactive protein is very important that we are doing in our lab. High sensitive C-reactive protein serum amyloid A and fibrinogen. Normally, most of the labs will be doing C-reactive protein, and this is a marker, and we can know that if the C-reactive protein is elevated in a patient with acute coronary syndrome, if you treat the patient, and if the patient with an elevated C-reactive protein will benefit more than person without an elevated C-reactive protein. So it says that the inflammation, the degree of inflammation is being given by the C-reactive protein. And once there is a damage, you can have increase in the myocardial markers, which are troponin, CKMB, and these days you will do brain natriuretic peptide. Brain natriuretic peptide is basically a molecule that is protein that is secreted from the myocardium, ventricular myocardium, also from ventricular myocardium mainly, and this is elevated in several conditions. One of the conditions is acute coronary insufficiency. This is also elevated in heart failure. So as I was telling that inside the vulnerable plaque, this is a basically vulnerable plaque. So you get me, I mean the point is that vulnerable plaque is a plaque which is prone to rupture. So there is, it has been found that the C-reactive protein elevation, the level of C-reactive protein elevation is directly related to the temperature inside the plaque. I was telling you about the hot plaque. So that the temperature inside the plaque is directly related to the C-reactive protein. And again, the interplay in between inflammation, thrombosis, which is by the tissue factor, which gives rise to acute coronary insufficiency. The coagulation cascade takes place. So it's basically an interplay in between the cardiovascular risk factors, inflammation, and thrombosis, which give rise to acute coronary insufficiency. So you can see here the difference in between a vulnerable plaque and a stable plaque. You can see stable plaque will have a very small lipid core. Majority of the time it will have a heavy fibrous deposition causing a luminal obstruction. Most of the patients will present with angina for years together, but they will not have acute coronary insufficiency. Even if they have, their chances are less, maybe 9 to 10%. Whereas here you can see there the importance is that the plaque is vulnerable, the fibrous cap is very thin, and the lumen is large. So it is not necessary that you have to occupy the whole of the lumen to get a acute coronary event. You can have a plaque rupture here, and the rest is done by a thrombosis of the vessel, which causes a total occlusion of the vessel. So what are the psychological triggers? We know the psychological triggers can cause a plaque rupture. So you can see that there can be early morning stress, and we know that the peak time period of acute myocardial infarction is the wee hours, the early morning. And these are the triggers that happen which causes a plaque rupture, and you will find thrombotic occlusion at sites with less severe stenosis, as I have been telling all through my discussion. And there is early morning stress, and beta blockers which cut down the sympathetic activity, they have been known to modify acute stressors and decrease the incidences of acute myocardial infarction. Now from plaque to thrombosis, this is a slide which shows that there is a partial occlusive thrombus. If you have total occlusion of the lumen by a total occlusive thrombus, you will get an ST elevated MI. You will have an ST elevated myocardial infarction. If you have got a partial occlusion where the vessel flow is not disrupted, you will have unstable angina. You can have a non-ST elevated MI with marker elevation.
Yeah. Dr. Lahiri, I think that is a wonderful presentation, but due to shortage of time, we will stop here. We have received two messages from our student, one Dr. Arun from St. John Hospital, Bangalore, and his friend. They are basically enjoying this program, and one more student sent SMS saying that excellent presentation, but he didn't write his name. What I am requesting all of you is, you can call your people. All these students, I am requesting you again, all of you can call your people sitting at home, whosoever is having DTH, that is direct to home TV. It may be the Tata Sky, or it may be like Dish TV or so. So you can find out this program in Gyan Darshan 2. This is what our protocol is saying. But if you have any problem, you can just inform us. Better if you have DTH service at your home, no need to come every time at the studio for this program. So I would like to request all of you, please just call your home or some of your friend who can access this DTH and find out whether this program are available or not, because after 15 minutes break, 12 o'clock onward, again we will have the same program continuation of the same program, where I would like to ask many questions to Dr. Lahiri, and all of you are also requested to send SMS where you are and how much you have been benefited and what are the questions you want to ask, because unless you interact, we cannot know that where you are and how much you are understanding and all these things. And this is very true that sitting in a dry room like this and talking to only camera is very difficult. I know Dr. Lahiri is managing it, but I hope all of you can make it interesting, and after 15 minutes we will meet with the same type of continuation with this topic. Thank you very much.